Welcome to the module Depression and Dementia. In this module and throughout the series, the terms persons living with dementia will be used to emphasize that dementia is a diagnosis and does not define an individual. Dementia is a highly stigmatized disease process. The term persons living with dementia is used to promote positive language and a more person-centered approach. The purpose of this module is to discuss the neuropsychiatric syndrome of depression. Depression is a mood disorder that frequently occurs in persons with dementia. Persons living with dementia are twice as likely to experience depression. More men living with dementia and disability have depression than women. 25% of persons living with mild dementia have a diagnosis of depression. The risk for depression varies by the type of dementia. Persons living with Lewy body dementia are the most at risk for depression. Depression commonly accompanies vascular dementia. Depression frequently presents in mild cognitive impairment and in early stages of Alzheimer's dementia and may worsen over time. Depression is a risk factor for Alzheimer's dementia, especially for older adults with mild cognitive impairment and active depression. When MRI imaging was studied over a 2-year interval in adults 60 and older, in persons without dementia, hippocampal atrophy on imaging is associated with depression severity. Conclusions from this study indicated that future studies are needed on hippocampal atrophy as a biomarker for cognitive decline. According to the Diagnostic and Statistical Manual, depressed mood or loss of interest in pleasurable activities almost every day are the primary indicators of depression, along with decreased concentration, changes in weight, loss of energy, feelings of worthlessness or inappropriate guilt, slowing of thought and physical movement, hypersomnia, or insomnia, as well as recurrent thoughts of death with or without pain. There are several screening tools for depression. The short-form geriatric depression scale is a 15-item instrument that can be used to assess patients living with mild to moderate dementia. The geriatric depression scale has a 92% sensitivity and an 89% specificity, but does not screen for suicide. Depending on the stage of dementia, the Patient Health Questionnaire, Cornell Depression Scale, and the Hamilton Depression Scale are other tools that can be used to screen for depression in older adults with dementia. Depression often presents with multiple chronic conditions. In addition, there is an overlap between depression and dementia. Both diagnoses can be insidious. The diagnosis of dementia becomes clearer when depression is recognized and treated. Depression with psychotic features adds another layer of complexity in the diagnosis of depression and dementia. Persons living with dementia typically do not present with sadness. More subtle symptoms such as sleep disturbance, fatigue, complaints of pain, or anorexia are common symptoms of depression associated with Alzheimer's dementia. Recognizing how depression with psychotic symptoms contributes to cognition explains dementia syndromes. Although treatment for non-psychotic depression has mixed outcomes, early treatment for persons living with dementia, depression, and psychotic features result in improved cognition. In the presence of executive dysfunction, older adults with late-onset depression have poor memory when compared to those with early-onset depression. Non-pharmacological interventions are first-line treatment for depression and dementia. Early treatment can prevent neuropsychiatric symptoms. Exercise is known as an effective intervention to enhance cognition as well as improve symptoms of depression. Cognitive behavioral therapy, as well as music, simulated presence with video or audio tapings from family, aromatherapy, or pet therapy can be used to treat depression. Selective serotonin reuptake inhibitors may be used for clinical features with mild to moderate intensity. Mirtazapine may be considered for those who have poor appetite, sleep disturbance, and depression. Selective non-epinephrine reuptake inhibitors may be used for symptoms with moderate to severe intensity. Combinations of medication classes may be used for more severe depression. Cognitive behavioral therapy and pharmacology yield the most optimal results. Electroconvulsive therapy can be used for persons who do not respond to cognitive behavioral and pharmacological therapies. Treatment promotes optimal quality of life for the persons living with dementia and their caregivers. Complex assessment, treatment, and management is needed to prevent suicide, the poorest outcome of depression in persons living with dementia. During the time interval for one study, the rate of suicide was 0.09%. In a large national cohort study of participants over 60 years old, risk factor for suicide for older men, history of inpatient psychiatric hospitalizations, and the use of anxiolytic medications were included. Most suicides were in younger patients who were early in the diagnosis of dementia. Firearms were a common method for suicide. Nursing home placement is a reduced risk factor for suicide. Because suicide is the most severe but preventable outcome of depression, assess for suicidal ideation. The geriatric depression scale does not assess for suicide, so the provider must add the assessment. Follow-up with psychiatry early in the diagnosis of dementia is one prevention strategy, especially when there is a history of depression or previous inpatient evaluation. Removing firearms is important. In summary, depression is a risk factor for dementia. Symptoms of depression are atypical, and persons living with dementia may not verbally express emotional distress. Symptoms of depression are often overlooked. There are many overlapping symptoms of chronic illness and dementia that may overshadow symptoms of depression. Early detection, treatment, and management of depression improves quality of life for both persons living with dementia and their caregivers. Thank you for attending the session, and we hope that you'll come back to listen to other modules on neuropsychiatric symptoms in dementia.